Welcome to the HealthspanMD podcast. Welcome to the HealthSpan Podcast, where we talk about the 3 essentials of longevity. That's Medicine 3.0, proactive healthcare, building a strong body, and maintaining a sharp mind. And if those are your goals as well, we have a special guest with us today who is an expert at what I believe is the biggest threat to longevity, but also the biggest opportunity, and that is metabolic health. Dr. Heather Saran is a board-certified endocrinologist, boy, man, those are in short supply these days, who is passionate about partnering with her patients to develop a comprehensive evidence-based treatment plan that emphasizes preventive, proactive care. She's been recognized as a top doc in Scottsdale and in Phoenix, and she recently opened her own innovative practice, Bright Endocrinology. Welcome to the HealthSpan Podcast, Dr. Saran.
Thank you for having me.
It's a real pleasure to have you. You know, there are going to be a lot of people who are interested in listening to this podcast because, as we talked about, endocrinologists are in short supply. Like when I send somebody for an endocrinology referral, I'm expecting 2, 3, 4 month wait list, to get people in.
There's really long waits.
Yeah, and you're in high demand because you're expert at 4 of the topics that are really the hottest in longevity these days: metabolic health, sex hormones, thyroid hormones, and bone health. Let's just start with, what are some of the biggest misconceptions that people have about hormone health and its impact on longevity?
So endocrinology is the study of hormones, but when people hear hormones, they immediately just think about reproductive hormones, estrogen, testosterone, and that is a part of what I do, but it's not the biggest part of what I do. So some people are surprised to find out that insulin's actually a hormone, so I manage a lot of diabetes. Some people don't understand that you can have hormone problems at any age. It's not just as we're, getting up there in the years. And a lot of people, specifically when it comes to thyroid, because that's so popular, is people just relate it to their weight. I can't lose weight. It's got to be my thyroid. It could be, but your thyroid regulates a lot more beyond that, as you probably know. And there's a lot of misconceptions. So especially when we're talking about hormone replacement, a lot of women out there are afraid. And for a lot of people, hormone replacement can be safe. You just have to be in the right hands.
Gosh, there's so much to talk about there. Let's start with the sex hormones. Traditional medicine, I think, has just dropped the ball on hormone replacement and treatment. I remember very distinctly when I was in medical school being told, like, just about every woman who's postmenopausal should be on estrogen replacement because it's good for your heart and it's good for your bones. And then, I didn't go into endocrinology or primary care, but there was this big backlash. So the pendulum swung and is like, no woman should be on hormone replacement. Now we're realizing neither of those extremes are really the right approach. Can you talk a little bit? And I think the story is not too dissimilar in male hormone replacement as well. Talk a little bit about, how that has occurred and where you sit on that spectrum.
So there is a lot to unpack here. Like you said, when you were training, everyone should be on it. Then there was a big study called the Women's Health Initiative that came out, and it was showing higher rates of stroke and fatalities for women on estrogen. But this wasn't really replicating real life. They just randomized older women. A lot of them were maybe in their 70s. It'd been, a decade or two since, they went through menopause. And so what we've taken away now, looking back, where we can go through, we still have the data, we can separate those groups and see that it was those older women's having those problems. And for women who are kind of transitioning through menopause, that it is perfectly safe to put them on hormones. So most doctors that I work with will kind of use a cutoff around if it's been 5 years since your last period of that's when it's okay to start. But then there's also differences in the type of estrogen you use or the type of progesterone. So while everyone's afraid of estrogen, it was actually a lot of the progesterone that they were using that had the higher risk for clotting in that study. And then talking about, disparities in medicine, a lot of it does go back to training where we don't get a ton of that on reproductive. And, I'm an advocate for women's health, but there's, a big discrepancy where women are kind of left out of the book. I don't know if you follow Dr. Marie Claire on Instagram, but she talks a lot about this, and she wrote a book that was a big bestseller about menopause. And you compare how many studies are out there for men. It's in the millions. We're talking about low testosterone. We're looking at women in menopause. We're talking 100,000s. We're talking perimenopause, maybe tens of thousands. And it's not always part of the training that we receive.
Yeah, no, there's so many good points in that. And you're right. Like my medical school class, so I graduated in 95 from the University of New Mexico. And as I understood it, I don't know that this is true, that we were the first medical school class that had more women than men in the country. And so I grew up with that culture. Now I think women are just, nationwide more women than men in medical school. But
it's close to 50-50, but there actually are now more women entering medicine.
Is there, yeah. So, but we know our mentors, our trainers, vast majority were men, right? Like that was medicine back in the 60s, the 70s. And that led to research studies being designed with that male focus in it. So as you note, there's a lot of different variables, and it can be hard to answer questions based on evidence-based when, there's variations in dosages, in delivery methods, and, combinations of estrogen, progesterone, all of those things. Give us the woman that you feel like would potentially benefit from hormone replacement that maybe isn't getting offered that.
So as women enter perimenopause, things kind of slowly start to decline, and it can be subtle. So sometimes people just think, oh, this is how I am now. It's gradual. It's not like you wake up one day. So women are still having periods. They may be slightly irregular, but they can't sleep. They might be having hot flashes or just their hormones are throwing them off at night. I see a lot of women who complain of brain fog. These are high functioning women, and they're like, it takes me 10 seconds to think of the word, or I walk into this room and why am I here? So those are kind of some early signs because your brain needs estrogen. Women may develop as they go through menopause, vaginal dryness, pain with intercourse. We want to keep everyone and their partner happy. So even for women who can't take systemic estrogen, there's still options for vaginal estrogen, so they can still have a healthy sex life.
Yeah. So in your opinion, then, it sounds like that there are definitively women where the benefits outweigh the risk. And is that only in women that would have symptoms? Like, is there any role for estrogen replacement or hormone replacement in women as a proactive measure? The woman says, look, I don't have any symptoms. I feel good, but I want to stay young. Is there any role there, or is there not enough known?
There's no guidelines on that, so everything just has to be an individual decision.
Sure.
A lot of my patients don't want to take medicine unless they have to, so if it's one of those questions of, do I have to take a medicine? Then the answer is no.
Right.
But we need more research to see if, yes, that could be beneficial for women in perimenopause. But I can tell you getting a good night's sleep really does increase people's quality of life.
Oh, yeah.
And metabolism, having the energy to exercise, things like that.
Yeah. And we have similar issues on the male hormone replacement as well. I still remember seeing a patient when I was a resident at Mayo that he was a man in his 40s, I guess, and he was on TRT and testosterone replacement therapy. And the doctors were aghast. Like, this was, late 90s, and like, oh my gosh, he's taking testosterone. It was, and everybody told him, oh, you're going to, higher risk for heart disease, higher risk for prostate cancer. And I remember him just saying, okay, I hear you, but I feel great on this.
Right.
Like, this has really made a difference in the quality of my life. So you just stick to what you know, and I'm going to stick to my testosterone replacement. Now, though, that pendulum has swung to where we have clinics on just about every corner, it seems like.
Yeah.
And at least limit. I don't want to, cast stones here, but I've seen a number of men who have been to these testosterone-only clinics, really. They're getting huge dosages of testosterone. When one gentleman in particular, he's 32 years old. He's not had children. He's on testosterone with results of 3 times higher than the upper limits of normal. And I said to him, so you know that this long term you're not going to be able to have children likely. And he said, no, nobody told me this. And so that's an egregious example. I'm not saying everybody does that, but I don't know, testosterone replacement, maybe men are different than women. It just seems like every man's like, oh, testosterone? Yeah, I'll take that.
I think a lot of people start it not understanding the
Right.
risks or the long-term consequences. And there are people who make a business out of, selling testosterone. There's people in my complex, and I see men coming in every week to get their shot, and it's expensive, and I never know if they really need it or not. I have a lot of those people coming to me afterwards saying, do I need this? And unfortunately, kind of once someone's already started, it's hard to know, do they need it or not? The feedback, the hormones, the pituitary, I can't check their FSH, their LH to say, do they have primary or secondary hypogonadism? But I will work with people on maybe weaning back their dose a little bit. Some people, we've tried to wean it with the goal to stop, and they didn't feel good. So we put them back on it, but we just have them at, healthy levels. So
Right.
when I replace testosterone, I'm not trying to make people the Hulk. I'm just trying to get them, back to where they are. You probably know the data better than me as far as cardiovascular risks, but it's a little mixed out there. So again, just taking in account everyone's individual risk factors, their family history. And, if you think about, a man with normal testosterone levels, someone who's healthy, who feels good, and they have a heart attack, are you going to castrate them? Are you going to take away their testosterone? No. So why are we denying men who need testosterone just to get up to a healthy level?
Yeah. That's, and I think we have struggled with that in cardiology. The same is that older studies, not as well done, had some suggestion that testosterone replacement could increase cardiovascular events. That subsequent studies have not shown that, but then the best study was a New England Journal within the last year, did not show an increased risk of cardiovascular events on testosterone replacement, but the replacement was testosterone cream, and they were only achieving 300-400 type levels, not higher levels. And so still some uncertainties, but I guess my approach generally has been, is somebody who's had a heart attack in the last year, I'm saying let's hold off, until we get through that. But then again, somebody who's not high risk, that has symptoms that are affecting their quality of life, I'll have the talk with them and say, look, if there's a heart disease risk to this, it's probably low. We haven't really been able to show that definitively, but it's probably low. But man, your symptoms are ones that may really benefit. And I have men that say, look, even if it is increasing my heart disease risk, I feel so much better on this.
It's a trade-off. I mean, it's a balance. It's quality of life. Do you want to live forever, or do you want to feel good?
Yeah, yeah, that's a good way of putting it. So let's move on to. I'd say that what I talked about in the beginning was, I believe the biggest problem in healthcare, the biggest disease with the biggest impact, is metabolic dysfunction. And people, I talk a lot in my practice about insulin resistance, and very few people understand what I'm talking about, because they're like, patients say, ooh, what's that? And I realize one of the challenges in metabolic dysfunction is that it goes by so many different names. We have diabetes, we have prediabetes, it used to be syndrome X, we have metabolic syndrome, we have insulin resistance, glucose intolerance. All of these things, and then it manifests in different ways, PCOS and, heart disease and cancer and stroke and dementia. Like, all of these things are kind of underlined with insulin resistance. And, if we define metabolic dysfunction as those 5 criteria of metabolic syndrome, of having at least one of them, there's an NHANES study that says 93% of adults have at least one of those. So you are, as you just pointed out in the beginning, you're a hormone expert. Yep. Insulin is that, is a hormone. How is your kind of, your experience with diabetes, prediabetes, those things? How has that evolved over your career, and how do you see it today?
So I see, kind of the whole gamut of that, in my career so far. So, when we talk about insulin resistance, it's a whole spectrum.
Right.
So I have some people who have normal blood sugars levels, but it takes a whole lot of insulin to keep it normal.
Yeah.
And so those patients are at risk for going further in that spectrum to prediabetes and then ultimately type 2 diabetes. When we get to type 2 diabetes, then we know that there's just not enough insulin in the system to keep those sugars down. And that's when people usually need medications. I have some people who, again, some of my patients say, I'll do anything, I don't want to take medication. And I see people make changes to their lifestyle. You know, if they were drinking 12 Cokes a day and they stop, I've had people go from an A1C of 10 all the way down to 6. So, you know, changes like that can make a huge difference in someone's long-term health care.
Yeah, I had to learn this. I guess I'll take a step back. I do see a lot of people who come in with pre-diabetes level A1Cs, clearly insulin resistant, and you ask them, how's your sugars? And they'll say, oh, my doctor told me they're fine, because they're not diabetic yet. But that point that you make about, people being insulin resistant that have normal blood sugars, the patient who showed me this was about 3 years ago. I had this young woman. She's in her 30s. She's a breast cancer survivor, really interested in her health, morbidly obese. She was not able to lose weight, even though she was doing all the right things. And I'm like, man, it just seems like insulin resistance. But her A1C was optimal, 5.2.
Wow. Fasting
blood sugar was 90s, and I'm like, but her sugars are fine. We did an oral glucose tolerance test on her, and her baseline insulin was like 67.
Wow.
And it went to over 200 with the glucose challenge. And I'm like, now it makes sense. You're generating so much insulin to, keep those sugars normal.
Right.
But with that level of insulin, you're not going to access your fat. Like that's,
right.
You and I, we have the power, like all doctors do, or anybody who would give somebody insulin. We can make anybody obese with enough insulin, right? So it's an interesting thing that I think medicine is still trying to figure out. But now, I'd also say this is really important because, well, when I first started, there wasn't really proven therapies that were saving lives in diabetes, right? We were giving people with high insulin levels more insulin. That maybe a little questionable there. We had, these, medications now have glyburide, and I can't even remember what they call those.
The sulfonylureas.
Sulfonylureas, yeah, there you go. But now we have at least 2 classes of medication that have clear mortality benefit.
Yes.
Maybe even, more exciting than that. Like these are, if we talk about the GLP-1s, I mean, people know that as Ozempic, Mounjaro. These have these medications mortality benefit in people with diabetes. They're not. They lead to pretty dramatic weight loss in a lot of people, but they also mortality benefit if you have advanced heart disease. They slow renal disease progression in people with renal dysfunction. There's some early evidence of slowing cognitive decline in Alzheimer's and Parkinson's. New England Journal within the last month, people with osteoarthritis that were considering knee surgery markedly decreased the need for knee surgery, knee replacement surgery, independent of weight loss. So a lot of interesting things here. How have these tools impacted the way you take care of people with diabetes and insulin resistance?
So the way I take care of diabetes is trained. It's changed since I was training. Yeah. So, a lot of these medicines didn't exist. So, as physicians, we always have to learn what's the newest medicine, what are the latest studies on them. And like you said, we're finding, kind of one of the side effects of it is positive. People aren't having heart attacks. People aren't hospitalized for heart failure anymore. With the GLP-1s and the kidney, it hasn't, made the FDA label list, but I imagine that's coming based off the recent studies. And a lot of the other specialists that I collaborate with, I'm seeing kidney doctors, I'm seeing cardiologists like you, prescribing some of these medicines. And I think one of the biggest changes that this is here to stay is Medicare has finally cleared one of these medicines. So if you don't know, Medicare has never covered a weight loss medicine ever, and it's not covered for weight loss, it's covered for heart protection.
Yep. Yeah, I've yet to have a patient that has gotten it paid for yet, but I've tried. And so we're working on it. Insurance companies, we won't go down that route, but that path right now. But, one of the things that is occurred to me, diabetes, I knew from my training as cardiologist that, it's a cardiovascular risk equivalent, meaning that people that have diabetes have the same risk as somebody who's had a heart attack for future heart disease. Recent studies showed that, if you look 10 years before the diagnosis of diabetes, those people have about double the risk of heart disease before they have diabetes as people who don't. And then after they have diabetes, it's about double the risk. So there's a lot of opportunity there to, if we're interested in prevention, which I am, as a preventive cardiologist, sometimes I'm starting to think, well, I could boil my job down to, if I can help somebody reverse insulin resistance, then I've done my job. I've made huge leaps in preventing heart disease in that individual. And as you know, very astutely pointed out, it's not just medications. Like, there's a real impact to, our nutrition strategies, our physical activity strategies. Can you talk a little bit about how you advise people that maybe they're pre-diabetic, maybe they have signs of insulin resistance, and how they might be able to impact their future health with changes they can implement now?
So diet and exercise goes a long way, but for some people it's not enough. That's really when they need medication. Some people I may recommend a few supplements that can help with insulin resistance. So those are some things you can get over the counter that can help. I kind of look into what are the nitty gritties of their diet. There are things that people may not understand that they are labeled as healthy. They may not understand derailing their weight loss efforts, their insulin resistance. So it really has to just be a unique kind of tailored approach. And at my practice, I have the time to do that where a lot of other endocrinologists don't. Yeah,
it's such a good point that, there's not a one size fits all. People kind of understand that about diet. Okay, yeah, I understand that one size fits all, but we're still looking for that simple thing, right? And my sister-in-law found a low carb diet, did a low carb diet, and they got amazing results. That should work for me. Not recognizing that there's so much individual variation.
Yeah, and there are some studies. There's a little bit of data on things like the keto diet or doing intermittent fasting that can have benefits on insulin resistance. I'm a big fan of moderation, but I have had some people with huge success. So if that means that you're not sitting on your couch munching while you're watching Netflix, then sure, intermittent fasting is for you.
Yeah, it's something that I've had patients who have gone. This was an epiphany for me. I'll actually tell a story about the two doctors. So I had two doctor friends of mine. One of them was my college roommate, and he. I hadn't seen him in a while. We got together and he looks amazing. He's like, he lost a bunch of weight. He felt great. And I'm like, how did you do this? And he said, keto diet. I'm like, oh my gosh, really? Well, that must be the way to do it then. And then like the next day I run into another colleague who I hadn't seen in a while and he looks great. And I said, how did you do it? And he said, whole food plant-based diet. and I'm like, wait, these are exact opposite diets. Like it doesn't make sense. But what I've learned from this is that, what's the commonality between those two diets? Low and highly processed foods. Like that, you start there. That's a really big, place to start. But also what works is going to be unique to you. You have hypotheses. You say, I'm going to try this, approach. And then you look for the results. If the results are you can't live with that diet, that's not a non-starter, right?
I think that's a big problem with a lot of these diets is people do it, but they can't sustain it.
Yeah.
And so a lot of times the weight will kind of bounce back.
Yeah.
So that's why I'm a fan of kind of moderation and just picking up some healthy habits that you can sustain and just talking to my patients like, is it reasonable for you to do this? You don't have to go out and train for a marathon, but can you walk the dog an extra block?
Right.
Let's start there.
Yeah. Beautiful. So we hear a lot about the importance of mitochondrial health and metabolic aging. Can you explain the role of mitochondria in this process? Like, how do they, how can we protect, enhance our mitochondrial function as, time goes on?
Yeah, so mitochondria are kind of the powerhouse of the cell. So that's where a lot of energy production comes in. So the mitochondria can affect your metabolism overall. They play a role in cell signaling, kind of the way your body talks to itself. And it tells a cell kind of when it's time to die and let a new one come in. So the mitochondria do play a role in your energy balance. And there are some things, and I don't want to sound like a broken record, but diet and exercise can make a difference. So when we're talking about exercise, it's great to do cardio, aerobic exercise, so that can, make energy production. Also, strength training has been found to increase the number of mitochondria that might be found within that cell, giving you more energy. And just kind of having a balanced diet, so certain vitamins, the B vitamins, just kind of that general class. Magnesium is a mineral, but that's been shown to have a positive effect on mitochondrial health. And coenzyme Q10, that is one of the ones that if people are really interested in this, I probably recommend as a supplement. So, it is naturally found in foods, but not a lot of us want to eat sardines all day, or, we're looking at liver, probably not the healthiest thing for you if you're looking for longevity. So kind of a balance of good old diet, exercise, good nutrition. The things your doctor's probably already been telling you, there's a reason. They may not know it has to do with mitochondrial health. But when we get down to the nitty gritty and the science of it, it does make a difference.
Yeah, so I want to talk a little bit about coenzyme Q10 because that's a big one in cardiology, right? And the rationale behind this is that statins, a commonly prescribed medication among cardiologists, is can deplete coenzyme Q10 in the muscle, and is that related to the symptoms? About 10% of people will have side effects on statins, myalgias or muscle aches, and does coenzyme Q10 prevent that? And it, my experience has been it's at least anecdotal. There's a few people who say, oh yeah, I had problems, but when I started coenzyme Q10, my problems went away. But I also, I can't discount the placebo effect. And there was supposed to be a big trial that was really going to answer this question, released a couple of years ago. I can only guess that it was delayed through COVID and all those things. So we still haven't had a really good, placebo-controlled randomized trial of coenzyme Q10, but I'm dying for that. Like, I'm really curious.
I can tell you, I anecdotally took coenzyme Q10 for a little while. I was talking to my hairdresser, so this is not, something I learned in med school, but I was struggling to get pregnant. She said, I talked to a lot of women, tried coenzyme Q10, did the trick.
Really?
Yeah. No joke. Next month.
There you go. Oh, that's gold. Like you heard it here. We've cured infertility
I wish it was that simple.
In the podcast. So let's switch over to thyroid health. I mean, for something that is so elegantly described in medical school, like the physiology. I have to tell you, if I wasn't a cardiologist, I would have been an endocrinologist, because the pathophysiology of the endocrine system, like the feedback loops and all that, like, was just so cool to me. I just thought it was really interesting. But the actual, taking care of thyroid is way too complex. It started with my one of my mentors talking about sick euthyroid when I was, and I'm like, oh, okay, now my mind's blown. Like, wait, the lab says this, but it's not really true. Like, what do I do with that? And now it's, there's subclinical hypothyroidism. What do you do with the TSH is a little bit high, with the T4? All those things. Can you help us understand how thyroid and all those things impact our health, our longevity?
Yeah, so I think people are so confused when it comes to thyroid, because the most common lab that we check is called the TSH, thyroid stimulating hormone. And when that's high, it means that your thyroid levels are actually low. So a lot of times people don't understand if they're actually hypothyroid or hyperthyroid. Right. So I'll get a consult and a new patient coming in and they're like, my thyroid's high. And I'm like, is the actual thyroid hormone levels high? Are you hyperthyroid, or was it the TSH and you're hypo? So it can be the opposite. So sometimes when I see a new person, I don't know what I'm walking into. And then when you talk about subclinical hypothyroidism, that's, again, kind of a controversial topic. The guidelines say, you don't have to treat it until, the TSH gets above 10. Maybe the T4 is actually low. But T4 has to be pretty low for it to fall below kind of the reference range that the lab says is healthy. The TSH is really more specific to that individual and what they need in terms of pituitary feedback. But then it's a lot of talking to people about their symptoms. So if someone says, I feel great, I don't want to take a medicine unless I don't have to, you don't have to. You know, someone says, you know, I'm tired, I'm gaining weight for no reason. Well, then let's try it. You know, levothyroxine, I believe, is like the most commonly prescribed medicine in the US. It's perfectly safe. So it resembles T4, what your body should be making on its own. So if you take a pill every day, your body can't tell, you know, is it coming from this pill or is it coming from your thyroid? You know, so I see a lot of women who are pregnant, nursing, perfectly safe.
Yeah, so much to ask you about there. So, well, one, symptoms. Like, you know, that makes a lot of sense to me. Like, well, we should be, well, you know, who doesn't have some, you know, if you ask them about the symptoms of hypothyroidism, it's like, okay, everybody's got, you know, some of that.
Right.
And then but, you know, I also, maybe I'll throw out two things to ask you about. One is, I heard this once, and I think there's some validity to it, but it with caveats, and it was medicine has not taken advantage of the placebo effect as much as they could, and I don't want to get out on, okay, that means we just hand out sugar pills and you know, or a non-evidence based approach. That not what I mean, but. You know, if you saw somebody who's, you know, complaining of fatigue, of, you know, low energy, you know, weight gain, all those things, and their TSH is a little high, their, you know, T4 is, you know, lower normal, you give them a little bit of Synthroid and they come back and say, I feel great. Do you really care if it's placebo effect or not?
No.
Yeah, that's what I was saying.
I feel better. I mean, I've definitely had that scenario. I would definitely say, let's try it, you know, and I usually tell people this is just a trial. Let's give it a couple months. You know, I want to see you back. I want you to do some labs before you come in. And sometimes the labs get better and they don't feel any different. So then we say, it's probably not your thyroid. Right. You know, this is so subtle. So going back, like you said, the thyroid gets kind of blamed for everything because it could be the thyroid. It's got its hand in every organ system in your body. And sometimes people think, you know, oh, I need more. Sometimes more is less. If people are on too high of a dose, they can feel really run down too. Yeah. So feeling tired isn't specific to being hyperthyroid or hypothyroid. It happens on both ends of the spectrum. So some more kind of specific symptoms to look for, besides being fatigued, would be just kind of the body's generally slowing down when you're hypothyroid, you're tired, your brain isn't working. People kind of have that brain fog. Skin gets dry, the heart can go slow, people can get swelling in their legs if it's really bad. And then it can be the opposite if someone's hyperthyroid. Everything is sped up. So even the brain, I see a lot of people and they're very anxious and they don't know they're anxious. And sometimes they're angry at me and I've never met them before. Right. And I'll treat them and they come back and they are a different person.
How interesting. Yeah.
So I love it if someone brings in like a partner with them and say, is she acting differently than, you know, before? And then I reassure the partner, it's not her fault. You know, we will get her treated. She will go back to being, you know, the way she was. And people can get shaky, the heart can race, you know, so I get some referrals from cardiology because someone has newfound AFib. And it turns out it's probably their thyroid that flipped them into it, and they're probably not going to come out of it until their thyroid's adequately treated.
Yeah, anybody with new onset AFib, we check a TSH, of course. I always tell the residence fellows, like, it'd be embarrassing if we miss that, right? And it hardly ever comes back abnormal, but, you know, when
and now I
it
see
does,
people, their watch is telling them they have AFib.
Oh, yeah, true.
So we're catching this, I think, more often now.
We definitely get that. Tell me your thoughts on Synthroid versus Armour thyroid. Pandora's box.
So I'll start with, I usually start most people, if they don't have a medical issue, on a generic levothyroxine to see how they do. Okay. If someone is sensitive to the hormone, the active ingredients is the same between a generic and Synthroid. It's really those inactive ingredients that can change. So if, say, someone has celiac disease, they actually have a gluten allergy, a lot of the generic pills will use wheat as just a binder. You know, they've got to put the medicine and press it into a pill form. And so that's when someone definitely needs a brand name that's gluten-free. When I see people who have fluctuating levels, you know, the pharmacist might be getting 1 month from manufacturer A, the next month manufacturer B, and so the strength may vary a little bit. Some people are sensitive to that. And when it comes to, the levothyroxine or Synthroid versus Armour, I think the medicines like Armour desiccated thyroid hormone, it's just crushed up pig gland, but they've done a very good job marketing it as natural, and people love something that's natural. So it's interesting in the fact that it doesn't follow kind of the same FDA regulations. It's like a supplement that requires a prescription because it is like a crushed up gland. It's not made in a lab. And Armour's been around for a while. There's a lot of other brands that have kind of come and gone because their dosing is usually not as accurate. So some of them have willingly recalled themselves because what they say is in it isn't actually how much is in that. So I'll also see some people, well, their levels are fluctuating because, this pig thyroid was different than the other pig thyroid. And the thing you have to keep in mind is that the pigs have a different ratio of hormone in them. So a human thyroid will make about 95% T4, which a little bit of T3. And if someone's not familiar with T4 or T3, T4 is really more kind of the storage form. It's not as active. So, it's got to be made in your thyroid, circulate throughout your body, and then it's got to actually get into the cell. And in the cell, it converts it to T3, which is more active. So some people like the Armour that they're getting that T3, whereas Synthroid is just all T4. Most people will convert it. But there's some theories that some people are poor converters. And it may be true, but there's not, a standard test to know that. And so for some people, I will try that type of medicine, or I will add in a separate prescription on top of Synthroid for liothyronine or Cytomel, which is T3. And for some people, that makes a huge difference. They never want to come off of it. Some people initially feel good. I kind of explain, like, if you've never had coffee before, you're kind of like, ooh, I got a little more energy. But then once you become a coffee drinker, you don't feel like that anymore. Right. And so some people will say adding in the T3 made a difference, but the effect kind of wear off. And then it may not be worth having to take an extra pill, pay an extra copay if it's not making a huge difference. And I think we just have to be careful, who we prescribe those medicines with T3, since it is more active. We do get some side effects from that. So again, heart arrhythmias, so generally it's not considered safe in the elderly to have a higher proportion of T3. I'm always careful with my young women if they're pregnant or trying to get pregnant, because that T3 doesn't cross the placental barrier. So a woman's TSH may look perfect, but the baby's only seen that T4. And there's less T4 because that T3 isn't crossing over. So that's a lot of things. I even see OB-GYNs miss that one. And then I usually like to check levels, but T3 is so small, it is hard to accurately measure T3.
Interesting.
If you go to the beach, you can count buckets of sand. That's like your T4. Your T3 is like trying to count these tiny little grains, because I don't remember if it's picograms or nanograms, but it's small. So again, the TSH is still the best reflector of what your body's seeing overall, whether it's T4 or T3.
Beautiful. That's a great explanation. Endocrinology level interpretation of that. So now the last topic I want to talk about in regards to longevity that's critically important is bone health. And most people aren't thinking of endocrinologists as, experts at that, but you are. And, I think about when I'm talking to my, patients who are interested in longevity, we, start with this base of let's, getting metabolically as healthy as you can. Because if you're metabolically healthy, dramatically lower your risk of heart disease, cancer, stroke, dementia, quality of life. But another aspect of longevity I think of is building reserves. Building reserves of things. Like, we don't go into retirement with low financial reserves because we know we need those. There's other things that we know we're going to need. Time's going to take that away. Muscle, flexibility, cognitive function, all those things. Bones are part of that as well. I mean, one of the big distinctions between doctors and non-doctors, you tell a doctor, oh, my 80-year-old mom fell and broke her hip last week, and the doctor goes, oh, gosh, I'm really sorry. Whereas everybody else is like, I'm sure she'll bounce back really well, because we know those fractures into life are bad news.
Yes.
in this. Talk to us a little bit about bone health, how important it is to be screening for it, the therapies that we have for bone health these days.
So if someone has weak bones to the point that they're at risk for a fracture, we use the word osteoporosis, or if someone has broken a bone from something that wasn't traumatic. So if you fall down a flight of stairs, you can break something. We don't call that osteoporosis. But if you trip on a wire and you put your wrist out and it breaks, that's not normal. You shouldn't be breaking. That's osteoporosis, no matter what your bone density says.
Interesting.
So for a lot of women, bone starts to decline more rapidly after menopause. So estrogen's a really important hormone for your bones. So that's why we generally think of osteoporosis as more of a woman's disease. But it does happen in men, and especially if men have low testosterone, we see that. So this is where prevention is really key. And this is where I wish I could prescribe people time machines and go back, because your bone peaks when you're in your 20s. Now, when I was a teenager, was I worried about how much calcium I was getting? Was I getting a lot of exercise? People, when they find out, they want to do everything to try and get it back, but it is just a gradual decline with age. So past your mid-20s, it's kind of a slow decline, especially when women hit menopause, it's a much more rapid decline. So when I put someone on a medication and I'm following their bone density, even if I see no change from 2 years ago, I'm happy, because I know it would have gone down if we wouldn't have intervened if they weren't taking a medication. But we can see sometimes the bone build back up. So I kind of call that, reversing time. We're actually getting back to where the bone is stronger. But a lot of people are afraid of bone medicines.
Yes, I know.
And part of my job as an endocrinologist is not just here's your prescription, it's figuring out why. So there's a hormone called parathyroid hormone that affects your bones. A lot of people think about calcium for their bones, and vitamin D has become really well recognized for that now. One of the interesting things about vitamin D is that if we found it today, we would not call it a vitamin. It's a hormone.
Yes, you're right.
It's made in one place and it acts in another. That's the definition of a hormone. So vitamin D is not naturally found in a lot of foods. We add it into a lot of dairy products or non-dairy products. I see a lot of my patients, oat milk, soy milk, check the label, make sure they're adding the calcium, make sure they're adding the vitamin D. And a lot of people want to do exercise, but it's really when you were a kid that it was so important, trying to build your bone mass up. So I'm not discouraging anyone from exercise at all, but when you were a kid was when it was so important. So I'll tell my patients, I still want you exercising, because if you're active, keep your strength up, keep your core up. If you trip on that cord, you may be able to catch yourself. You may not have to put out your risk, to fall. Right. So just keeping that strength up, that really increases longevity. Some people are at the point where, it's just time for medicine. Otherwise, they're such high risk for breaking something. And as you mentioned, that 80-year-old woman, there's such a decline in people's quality of life. And don't quote me on this, I want to say about 25% of people die within 12 months of their fracture.
Yeah, I've heard 25, 30%.
Yeah. People also are just afraid, it gets in their head that, what if I fall again? So people don't want to go out, and they just start to become more and more frail. Yeah,
there's the virtuous cycle, and then there's the vicious cycle, and people get in this vicious cycle of, they're in, for example, pain. So they move less, which makes their pain worse, which just, it's they get weaker, and then they're more vulnerable with time. Well, you've mentioned several times today about having the time in your practice to sit and talk with people. And you've recently opened your own practice. You're using a direct pay model for that. Tell us about why that was important and why you opened this practice and with using that model.
Yeah. So I wanted more. I wanted more for my patients. I wanted more for me. I think a lot of people are frustrated when they go to the doctor and they've waited months and months to get an appointment, and then they're finally in to see the doctor. And studies show on average people only get 5 to 7 minutes actually face to face with their doctor. So I didn't feel like these are high-level things. There's so many factors to take into consideration. I didn't feel like I was able to do my job when this is just high-volume patient after patient with not much personalized attention. So I wanted to give people a lot longer of an appointment and have access to me where they're not waiting months. It used to be if someone, say they got sick, they couldn't come in, I couldn't schedule them for 3 or 4 months. Imagine if your thyroid's off and you're waiting 3 or 4 months to get in to see the doctor. Also, doing direct care eliminates kind of that red tape, the insurance bureaucracy. So I'm not in bed with your insurance company. I'm there to treat you. That's all I care about. So we still are stuck with some of the limitations of insurance as far as, talking about prior authorizations for some of these medicines. So we still definitely do that. My patients will use their insurance if they have it for their labs, for their imaging, getting their medications. But it's very clear, transparent pricing. So people don't have to worry about a surprise bill at the end. There's no copay. It just makes it easy for everyone. And people just have a much more relaxed experience when they're in my office. Just kind of the vibe, the colors. People have time. They're not rushed, try and ask all their questions. And it really helps kind of foster that patient-physician bond, that's so important if we're trying to treat someone. A lot of people are nervous when they go to the doctor. They don't want to get in trouble. So I don't think I've ever yelled at a patient, but people are still embarrassed. It's like being called to the principal's office. They're going to find out that, you didn't do your homework or something like that. So if I'm building those relationships with people, we can have an honest conversation so I can really give you the help that you need, not just the help that you think you need.
Yeah, that's so, the key word that you use in that is that relationship. It's something that I went into medicine. Of course, I've been a physician now 29 years. And, I went into medicine. I realized because I wanted that relationship with people, like I wanted to, work with people to help them improve their health. But by the time I actually became a physician, I realized that I didn't have time to build those relationships with people. And, I understand when people are frustrated with their physician when they say, look, I had 7 minutes with my doctor. I waited months for this, and they're upset with the physician. But, what they don't realize is that doctor was paid about $90 for a visit. If they sit and talk to you for more than 7 minutes, they can't make that work financially.
Right. And it's not that the doctor takes home that $90. There's support staff, there's rent.
Right. And generally, and physicians in these, I guess I was, employed corporate medicine most of my career. What the reality is, all of these doctors are generally the doctors are there because they want to do good things for their patients, and they feel terrible giving 7 minutes as well.
Yeah.
And so what they end up doing is taking a lot of the work home.
Absolutely.
With them. And there was a study a couple of years ago that said for every hour in face-to-face with the patient, the doctor spends 2 hours on the computer billing,
right.
All the other things that we have to go through.
So when I say I wanted better for myself, it's not just me. There's other people who rely on me.
Yeah.
So, I used to be kind of charting at night, things like that. It's like, okay, well, now I can spend that time playing with my kids because I'm caught up on all my notes. I can go out with my husband, and foster that relationship. So it's not just about me, but I think everyone can feel the difference.
Yeah. How has it been? You've been open how long now?
I opened in August, so it's been about 4 months now.
Yeah, and how's it been?
It's been fun.
Yeah.
Yeah, when people come in, like my old patients who followed me, some former staff have come in to say hi. Everyone just says, you look much more relaxed. Like you look happy, and I feel happy.
This is a terrible thing to say, but I won't say where I was from then, but we used to have this thing where somebody would retire or they'd leave, and we'd see them, months or years later, and say, oh my God, they got so much younger after they left. Like it was a real noticeable thing. Yeah, really
you
cool.
Think about your cortisol levels and how that impacts longevity.
Yeah, amazing. Well, I know there are going to be a lot of people that will want to connect with you after hearing this podcast. What's the best way for people to connect to you in your practice?
The simplest way if they want to make an appointment is just to call. You can also go to my website, brightendocrinology.com, and book an appointment that way. You can follow me on Instagram. It's dr.heathersaran. And I have a Facebook page. I have a very small YouTube channel. But if you want to call me, the phone number is 480-725-6025.
Thank you, Dr. Saran.
Thank you.
All content created by me and HealthspanMD is for general informational purposes only and is not the practice of medicine. No doctor-patient relationship is formed. The use of this information is at the user's own risk and is not a substitute for professional medical advice, diagnosis, or treatment. Hi, I'm Dr. Hurst. We created HealthspanMD for people who are dissatisfied with healthcare. Common complaints about healthcare include difficult access, poor communication, rushed appointments, disease-focused or sick care with little interest in helping people get or stay healthy, and little to offer beyond a prescription or a procedure for optimizing health. This type of healthcare is unacceptable, but most aren't aware that they don't have to accept low-quality healthcare. HealthspanMD provides exceptional medical care. That means appointments when you need them, time to talk to your doctor, get your questions answered, understand your problems, and get a clear plan to achieving your health goals. But it also means a comprehensive, proactive approach to your health that goes beyond prescriptions and procedures. As a HealthspanMD patient, you will get our expert, physician-led team of doctors, health coaches, dietitians, exercise specialists, mental health, and other health professionals to help you take advantage of your best opportunities to prevent, treat, and even reverse disease. And you may be eligible to have our care model reimbursed by Medicare and some commercial insurance. If you're no longer willing to settle for low-quality health care, schedule an appointment at HealthspanMD to experience health care as it should be.